comes when a patient has a clinically node negative axilla. So the clinical information can be derived by imaging, it can be derived by palpation, it can be derived by ultrasound. So basically whatever clinical data you have that is used to stage the patient, you do not find a lymph node. That is what your clinical data means. It can be radiological or it can be just clinical. So in a clinical node negative axilla, why the concept of sentinel lymph node comes in is because you're trying to reduce the morbidity of surgery. So if you look at the Halsterian concept of breast cancer, he believed that you remove everything possible, the patient will get cured. But then Bernard Fisher proved that wrong. He said breast cancer is a metastatic disease from the double cell stage. So that is why initially they went to very aggressive things and then slowly started becoming less and less aggressive, because these patients were surviving longer thanks to the advent of chemotherapy. The patients were surviving longer, and you were seeing a lot of these morbidities, even though the patients actually never had any problem because of the disease, but were suffering because of these other things. So that is why the role of sentinel lymph node biopsy comes. So in clinically node negative axilla, what the Almanac group did was they randomized patients to sentinel lymph node biopsy or standard axillary surgery, and they found that there was a significant benefit in the axillary lymph node group when you look at the risk of lymphedema or sensory loss. So here survival was not taken into the picture, but sensory loss and lymphedema were the two criteria taken into the picture, and in both of them they found significant benefit. Next was the just going through this just so that you know how they injected the dye, but it might not hold good in the present day, because in the present day what they do is a radiocolloid is usually injected into the periolar space or a peritumoral space just before the patient is taken into the OT, and then using a gamma camera they pick up the lymph nodes. Whereas if you're using methylene blue, the dye is injected much prior. I think it's Vishwajit, I think it's injected the previous day or 6 hours before. Vishwajit, is that?
Yeah, tell me now.
It's injected the previous day or 6 hours before, the blue dye?
I think 6 hours.
6 hours before, yeah. As far as I remember, it's 6 hours before. So the difference is the radiocolloid is injected just before, and the blue dye is injected 6 hours before. And what they do after injecting the radiocolloid is they give a little bit of a breast massage so that the dye goes into the lymphatic channels, and by the time you take the patient into the OT, induce anesthesia, this and all that, you get about 15-20 minutes. It would have gone into the lymph node, so you can use a gamma camera and pick up the hot node and by radiocolloid. Okay, so the NSABP B32 study, what they did was they randomized 5,600 women, and out of which they found about 4,000 had pathologically negative sentinel lymph nodes. Okay, so in this particular study, they took these patients, and in one group they randomized them to sentinel node biopsies followed by axillary resection. That is irrespective of the sentinel node status. In the other arm, it was sentinel node resection, and only in those patients who had sentinel node positive, they were taken up for axillary lymph node dissection. In patients who did not have sentinel lymph node positivity, they were not taken up for axillary lymph node dissections, and they were just closed up. So the point of this study was to find out if in these patients where you don't pick up a sentinel lymph node, is it possible to avoid axillary lymph node dissection completely? And what they found is the 10-year overall survival results, if you look at, is 87.8% for sentinel node and 88.9% for sentinel node and axillary dissection. So that is basically in the arm that comes negative, right? The overall survival is actually the same whether you do an axillary lymph node dissection after it comes negative or you leave it alone after the sentinel lymph node comes negative. So the Almanac study is something that proved that the lymphedema rates and the sensory loss rates were far superior when you did a sentinel node biopsy. The B32 study proved that in a randomized control trial, there is no drop in the overall survival. So the reason why all this came was there was a retrospective analysis earlier. So in the retrospective analysis from 7,400 women, they found that it was a safe procedure with a false negative rate of about 10 to 15%. So these false negative rates can be further brought down if you use both methylene blue as well as a radiocolloid. So if you use both, it comes down to as low as 7.7%. The other way to bring down the false negative rate is to increase the number of nodes that you you remove during a sentinel node biopsy. So if you remove one, the false negative rates might be around 18%, but if you remove two, it comes down to 12. If you remove three, it comes down to about 6%. So these are the ways by which you reduce the false negative rate. Other thing is you remove all suspicious as well as suppose even if a node does not take up the dye, but when you open up, you feel that node is slightly suspicious, that too can be removed in a sentinel node biopsy. It's not just you go, find a 0.5 centimeter node and leave a 2 centimeter node behind. That is not how it goes. So you, even if it doesn't take up the dye, you find something suspicious, you remove it. So that also constitutes a sentinel lymph node, because what you're trying to do is you're trying to find out if there's disease in the axilla. The assumption is the sentinel node is the first node that will get it. But sometimes that might not always be true. So you need to use a little bit of clinical judgment too. Okay, so the next thing is, so the standard of care actually even today is, if a sentinel lymph node is positive, you go ahead and do an axillary lymph node dissection. But there are two trials that actually try to challenge this. One was the Amaros study and the Akusak study. So basically what they did is, they tried to figure out if you could replace an axillary lymph node dissection with axillary radiotherapy. So Amaros was a non-inferiority study with which took early T1, T2 clinically node negative axillas, and they were randomized prior to SLNB to either lymph node dissection or axillary radiotherapy. So basically, before you know whether the node is going to come positive or negative, you are randomizing them. So the chance of a bias is much lower. So irrespective of the node, either the patients who were to undergo an axillary lymph node dissection would undergo an axillary lymph node dissection. The patients who were to undergo axillary radiotherapy would undergo axillary radiotherapy. And what they found is there was no significant difference between the overall survival rates, but the follow-up period was very short. It was about 3 years. But what they say is most of the axillary failures, right, if at all you don't address the axilla, they occur within 3 years. Axillary failures without addressing the axilla do not occur late. But I mean, of course, you can find axillary failures after addressing the axilla, that can occur late. But if you're left behind disease in the axilla, it will show up in 36 months is the assumption. So, but still completion axillary lymph node is considered to be standard. But if asked, are there any other options? Yes. So if one to two nodes, when you're about 3 nodes are positive in the axilla after a sentinel lymph node biopsy in a T1, T2 breast cancer, you can still cover that with radiation. So the advantage of doing that is you get a very, very good, the rates of lymphedema are far, far inferior in the radiotherapy arm as compared to the axillary lymph node dissection arm, and without much difference in the survival. Next is the Sentinel study. So the Sentinel study is a very important study because it's a very well randomized study. So what you should remember is the axilla is the most important prognostic factor in breast cancer. Neoadjuvant chemotherapy is the primary modality of therapy for all breast cancers right now, except for luminal A and luminal B cancers. The reasoning for that is in the Catherine trial, what they have found is in HER2 positive breast cancers who do not attain PCR after neoadjuvant chemotherapy, by hiking the therapy adjuvantly with TDM1, there is a benefit in overall survival. The other thing is in triple negative breast cancers, what the CREATEX trial has found is in patients who were given neoadjuvant chemotherapy and did not attain PCR, there's a role for adjuvant capecitabine. In a hormone positive, obviously we don't have such data, and hormone positive, you are not expecting pathological complete response even with chemotherapy or with endocrine therapy. So that is why if a hormone positive breast cancer is operable, that would probably go ahead for surgery. But otherwise, any tumor more than 1 centimeter that's triple negative or that's HER2 positive, I think most centers in India are now giving neoadjuvant chemotherapy. So timing of sentinel node biopsy in this neoadjuvant chemotherapy setting was very suspicious, because if all patients are going for neoadjuvant chemotherapy, then how do you bring in this concept of sentinel lymph node biopsy? Because sentinel lymph node biopsy is created that by taking up the fact that patient would not receive any treatment. You do an SLNB, you clearly stage the breast, you clearly stage the axilla, then you go adjuvant therapy. But that is no longer the pattern of care right now. So that is why this 4-arm study was done. So I think this part you must have heard, right? Navneet, did you hear this part?
No, sir.
This part also didn't hear? Okay. Okay, fine. So basically, this is the randomization. So in a clinically node N0 neck, you're doing a sentinel node biopsy. So in patients who come to have no node disease, you give neoadjuvant chemotherapy and do not address the axilla later because you've done a sentinel node biopsy and you found the axilla to be negative. The next scenario is after doing an SLNB, you find an axillary node. You don't do an axillary lymph node dissection. You close up, you mark that node, you give neoadjuvant chemotherapy, And then after that, you do a sentinel node biopsy with an axillary lymph node dissection, because that node was positive, but you're given neoadjuvant chemotherapy without addressing the axilla. So now you're trying to find out what is the accuracy of a sentinel lymph node biopsy being done after neoadjuvant chemotherapy. Next is, in a clinically positive axilla, that is arm C, you're given neoadjuvant chemotherapy. You're not done a sentinel lymph node biopsy before giving chemotherapy, because you know that this particular node is there by clinical examination. So now you only do a sentinel lymph node biopsy after giving neoadjuvant chemotherapy. So here you're trying to detect that even after giving neoadjuvant chemotherapy, if I do not find any disease in the axilla clinically, what is the actual disease burden in the axilla pathologically? So that is what that will pick up, the sentinel lymph node biopsy and axillary lymph node dissection done in a clinically node positive but YCN0 arm. Then obviously, if there is a clinical node after you're giving chemotherapy, there's no doubt about it, axillary lymph node dissection is the way to go. The next thing is, so if you go through the lymphatics of the breast, right, the entire breast lymphatics actually come and merge on to the periareolar region, and from the periareolar region, they actually go to the internal mammary, they go to the axilla, and they go to the supraclavicular region. So that is the reason this thing works. So, you might wonder, why am I injecting dye near the nipple when the tumor is in the outer upper quadrant? But the reasoning is that the anatomy of the breast is such a way that all these lymphatic lymphatic channels within the breast parenchyma, they actually go to the areolar region, and only from there they.
Sir, you are not audible. Sir, you are not audible.
Call him, I think.
Yeah, sorry about that. I got disconnected again. I'll start this again. Yeah, no, I got it. I got disconnected. Right? Yeah. Okay. Now am I audible? And is this other slides visible?
Yes.
Okay.
You got disconnected when it was in radio colloid.
Okay, that's right. Yeah. So basically, you might wonder why we are injecting the dye into the periareolar region and not next to the tumor. So if you go through the anatomy and the lymphatic drainage of the breast, the lymphatic channels in the breast actually converge in the areolar area, and from there they start moving on to the supraclav, the axilla, the internal mammary. Of course, there is some aberrant lymphatics that can go directly into the node, but generally this is the lymphatic drainage of the breast. So that's why you can either give it in the periareolar region or peritumoral region, and you will still be able to get the similar results. Okay, so this was how this is what happened after randomization. So out of the 1300 patients, they found that 700 were node negative and around 500 were actually node positive. So basically, in the patients that you thought were clinically node negative, you did a sentinel node biopsy. Out of that, you find that 40% of the patients actually had a pathological node. Okay, so that is one sort of data that you get. So you know that the patient is clinically node negative, but pathologically 40% of them might still have a node after you do a sentinel lymph node biopsy. Okay, the next thing is in the arm that was given chemotherapy, where they had clinically positive nodes. Out of the 800 patients that received neoadjuvant chemotherapy, actually almost 650, they could not detect a node clinically. So that arm also went for sentinel lymph node biopsy after that. And that is what we generally see. Usually after 8 cycles of chemotherapy, by and large, even if there was a 3 to 3 centimeter node, I think after the 4th or 5th cycle, it becomes very difficult to palpate it. So that is the kind of response that we expect with chemotherapy. So that's nothing spectacular. So the primary outcome of the study was to determine the accuracy of sentinel node biopsy, and which would be measured by the false negative rates in patients who presented initially with clinically positive lymph nodes and subsequently converted to clinically negative lymph node. That is after neoadjuvant chemotherapy. That is the arm C. The secondary outcome of the study was to detect the rate of sentinel lymph node biopsy before and after neoadjuvant chemotherapy. So basically, as I said, in a clinically node negative breast also, you're going to find 40% of the patient actually had pathological nodal disease. And one more thing that you get to know is that almost if you see these results, on hotspot scintigraphy, so the surgical detection rate in arm A and B was 99.1%, and the overall surgical detection rate in radiocolloid alone was about 98.8%. So the number of nodes removed also is given here. So most patients were removed between 0 to 3 lymph nodes, which is kind of currently the standard of care. And the surgical detection rates were slightly lower when you take these patients who were given neoadjuvant chemotherapy and then you did a sentinel lymph node biopsy again. So the false negative rates were significantly high in arm B and arm C, which I'll be mentioning here. So here. So if you look at the false negative rate was 51.6% in arm B and 14.2% in arm C. So arm B was that arm which was clinically node negative. We did a sentinel lymph node biopsy before neoadjuvant chemotherapy, and after neoadjuvant chemotherapy, went ahead and did a sentinel node biopsy and completed it with an axillary lymph node dissection. So in that particular arm, they found that the false negative rates was 51.6%. So how do you detect this? So first you have done a sentinel lymph node biopsy after you've given neoadjuvant chemotherapy, right? Then after that you did a full lymph node dissection. So the difference between the two is your false negative rate. Basically, if you picked up more the nodes on the axillary lymph node dissection that was not picked up on sentinel lymph node, that is your false negative rate. So that was the whole reason of the study. So the reasoning for this, but it was significantly lower in the arm C. Arm C was clinically node positive given neoadjuvant chemotherapy, and after neoadjuvant chemotherapy, you did a SLNB clinically where the node clinical node positive got converted clinical node negative. But the difference is you have actually touched the axilla before you're given neoadjuvant chemotherapy in arm B. That is, prior to neoadjuvant chemotherapy, you have done a sentinel lymph node biopsy. So you have changed the lymphatic channels. So that is why once you have done a surgical procedure, your lymphatic channels have figured out some new routes to go into the lymphatics now. So that is why the accuracy of that sentinel lymph node biopsy, once you have done it already pre-op, is very low. In fact, it is better, the false negative rates are lower when you don't touch it clinically, when you don't touch the axilla at all, but just after giving neoadjuvant chemotherapy, even if it is clinically node positive, you just do a sentinel lymph node biopsy. But obviously that cannot consider to be standard of care. The standard of care still happens to be clinically node positive, go ahead and do an axillary lymph node dissection. So what the overall false negative rate was 14.2% for patients who converted, and it was 20% for those with 1 or 2 sentinel nodes that were harvested. So you increase the number of sentinel nodes removed, the actual false negative rates start coming down. So use of additional blue dye with radiocolloid lowered the false negative rates. So as I said, there's almost a difference of about it halves the false negative rates when you use a dual tracer technique. So that also was proven. And I explained to you why in the clinical node negative patients who were taken up for neoadjuvant, sentinel node biopsy, given neoadjuvant chemotherapy, and then later on evaluated with a sentinel lymph node, why the false negative rates were higher was because you have actually done an SLNB before neoadjuvant chemotherapy. You have altered the lymphatics. So that is why, your SLNB is not going to work, because the dye is going to now take different paths. So you'll not be able to pick up the node that was initially cancerous. Okay. So the NSABP so the low detection rate and high false negative rates for SLNB after neoadjuvant chemotherapy can be explained by this. You have changed the order of lymphatics. The accuracy of sentinel lymph node biopsy was closely related to number of sentinel lymph nodes removed. That I've said again and again. And NSABP B32 found that a false negative of 9.8% was reported for all patients who underwent sentinel lymph node biopsy in primary surgery. However, women with one detected sentinel lymph node had a false positive rate almost 17%, But with 2, it was 10% or better. So it's better to remove more than 1 node if possible. Okay. Just to go through the ACOSAT study, I don't know how the order got changed. So for CN1 patients who underwent sentinel node biopsy after neoadjuvant chemotherapy, the false negative rate was 31.5% and 21.1% respectively for 1 or 2 sentinel nodes. Use of combined tracer was reported to have a lower false negative rate of 10%, whereas single tracer technique gave a much higher colloid rate. So actually, to be acceptable, your false negative rate should be less than 10%. Then you can accept it and probably can become the standard of care. So after giving neoadjuvant chemotherapy, just doing a sentinel node biopsy, your average false negative rates are about 20%. So that is why that is not, you cannot probably, you don't have a role of neoadjuvant chemotherapy in a clinically positive axilla. And then after giving neoadjuvant chemo, if it converts into a clinically N0 neck, you will not do a sentinel node biopsy, but in fact, you'll go ahead with an axillary lymph node dissection because the false negative rates found out in this trial were high. Okay, this we have already gone through. Okay. This is all about how it's done. Okay, now we'll just talk just about 2 trials I'll talk about for the next 10 minutes. Okay. So what is the NSABP and how was it formed? So basically, in spring of 1957, I.S. Rabden was the chairman of the surgical department in the University of Pennsylvania. They actually formulated the surgical adjuvant chemotherapy breast project, which was the forerunner for the National Surgical Adjuvant Breast NSABP. Okay. So today there are about 200 member institutions with 700 satellite sites located in the US, Canada, Puerto Rico, and Ireland. So it's the first research group to recognize the importance of including community-based investigators amongst its members. So majority of the participating sites today actually are from community-based institutions and not just from academic institutions. But in 1967, Dr. Bernhard Fischer took over as from the University of Pittsburgh, became the chairman of NSABP. So he succeeded Rudolf Nuhr. So basically the headquarters of NSABP moved to the University of Pittsburgh, and that is where the modern era of NSABP started. So they started taking the NSABP B1, B2, B4, B6, B5. So many of these very, very important trials were actually led by Dr. Bernhard Fischer. So Dr. Bernhard Fischer differed from Dr. Halstead, who believed that, the breast cancer is a local disease and you remove as much breast as possible and you will cure it. So radical mastectomy was the standard of care when Dr. Bernhard Fischer took over the NSABP. So what he tried to do was he tried to prove that radical mastectomy was not the right treatment for carcinoma breast, and less aggressive therapy would still give you the same results. Okay, so for that reason, they formulated the NSABP B04 protocol in 1971, and they tried to answer the question whether local or regional treatments other than radical mastectomy in patients with operable breast cancer would result in outcomes similar to that which was achieved with a radical procedure. So this study took around 1765 women. The initial results were published in 1977, and they demonstrated no significant difference between the 3 arms. Even at 25-year follow-up, actually there is no significant difference between the 3 arms. So, okay. So how they randomized was there's 3 arms were radical mastectomy, which was the Halstead's mastectomy, or total mastectomy, which meant complete removal of the breast, but sparing the pectoralis musculature and axillary lymph nodes, plus locoregional or axillary irradiation, or total mastectomy alone with no targeted axillary treatment. So actually NSABP B04 and B06 have been asked as short notes, just B04 and B06, because these are landmark studies. I think everybody should know them. So you need to know this randomization. So it's a 3-arm randomization that basically you're randomizing into 1 arm with total mastectomy, 1 arm with total radical mastectomy with axillary lymph node dissection, and 1 arm with total mastectomy and axillary lymph node dissection. So in clinically node, where patients who were clinically node positive, it was radical mastectomy with axillary lymph node dissection, or total mastectomy with RT to the axilla. So first, the inadequacy of clinical axillary lymph node dissection was demonstrated among patients with clinically node negative disease. So on those patients whom we thought had clinically node negative disease on an axillary lymph node dissection, 40% were actually positive. And the Sentinel study also showed that. A sentinel lymph node biopsy done in a clinically node negative axilla showed that 40% of the patient actually threw up a microscopic axillary lymph node. So because of randomization, one would assume that those patients the total mastectomy arm followed by radiation, or that arm randomized to total mastectomy arm were also node positive because it's a randomized control trial. So the assumption all the 4 arms have 40% undetected disease in the axilla. But what they also found was the axillary failure rate in the total mastectomy alone arm was only 19%, indicating that microscopic occult disease in the axilla may not always progress to clinically overt disease. Although this is not the standard of care, that does not mean you leave the axilla alone without a sentinel lymph node biopsy or not, but this is what this particular study showed. Okay, and it was a well-conducted randomized study. So the similar overall survival result among the 3 arms suggested that axillary lymph node dissection for clinically negative axilla is largely prophylactic, and the outcome is not likely to be significantly compromised by deferring the axillary lymph node dissection until there is clinical evidence of disease in the axilla. Going one step further, because axillary failure rate with the total mastectomy plus radiation was only 3%, it could be argued that total mastectomy plus axillary radiation is an alternative effective effort. But unfortunately, nobody actually tested this hypothesis for the next 35 years. So until Amaros and Akosov, nobody actually tested this hypothesis that you can replace surgery with radiation. But the Amaros and Akosov trial using sentinel lymph node biopsy as a guide has actually tested the same thing that actually primarily came from the NSABP B04 study, that you can actually replace treating this microscopic disease in the axilla with radiation. But of course, if the node is clinically positive, radiation does not work. It only works when it's clinically negative and you're looking at microscopic disease. So the B04, it paved the way for the conduction of the B06, which randomized patients with invasive breast cancer, less than 4 centimeters, to receive either an MRM, a lumpectomy, or lumpectomy plus breast radiation. Now, after 20 years of follow-up, there continues to be no significant difference in overall survival, distant disease-free survival, or distant disease-free survival in any of these groups. Okay, so this was a 3-arm randomization. The hazard ratio for death comparing lumpectomy or lumpectomy plus radiation was 1.05 and 0.07 respectively. So the recurrence, if you see in the arm that was given radiation, the local recurrence was 2.7%, and the local recurrence rates in general were lower because of the lower amount of local recurrence. So basically, currently the standard of care is that lumpectomy plus radiation is the current standard of care, because you are getting better local regional control, and of course it does not translate that much into an overall. I think the overall survival benefit as per the EBCTK meta-analysis is about 2 to 3%, but still there's a significant benefit in local regional control. So breast conservation surgery, as we call it today, followed by radiation, is the standard of care today. So the in-breast recurrences, they were actually 40% of the patients randomized to lumpectomy alone, compared to 14.3% in those patients again lumpectomy plus radiation. Chest wall recurrences were observed in 10% of the patients in the mastectomy arm. Nearly 3/4 of local recurrences in the lumpectomy alone occurred within the first 5 years of surgery, compared with lumpectomy and radiation arm, in which 40% of the recurrences occurred within the first 5 years of surgery. So next is, I think we stop. It's been an hour.
Continues. It's up
Should we
to you.
continue? Should we continue, or will we take it some other day? Because I'm also a little tired now.
Okay, then if you say so, we stop here.
Yeah, we'll stop here. So basically, what was the learning in this particular class was, you need to look at how to manage the axilla. What is sentinel node biopsy? What is your axillary lymph node dissection? When you do an axillary lymph node dissection, when do you do a sentinel lymph node biopsy? You need to know the Sentinel trial. You need to know the NSABP B04 trial, the NSABP B06 trial, and if you can remember, the Akosag and the Amaros trial would be very beneficial, because most people are from radiation, so there's a role of radiation in the axilla too. And also, you should remember what is the evidence for sentinel node biopsy. That is the Almanac trial and the NSABP B32 trial. So this is the basic funda of this particular this thing. We'll go through the other studies in the next classes. Okay, thank you. Any questions?
Hello, sir.
Yeah.
Hello, sir. What is the role of neoadjuvant hormonal therapy in this scenario of COVID? Can we use neoadjuvant hormonal in hormonal positive breast cancer?
Yeah, you can use neoadjuvant hormonal therapy, but Your overall response rates again depend on what will be the Aldred score. So if the Aldred score of the tumor is of the ER score is like 7 to 8, then you can expect an overall response rate of about 40 to 50%. But if the Aldreds are lower, the overall response rates are hardly 15%. And the PCR rates are less than 5%. So neoadjuvant, and you need to give it for at least 4 to 6 months. So neoadjuvant endocrine therapy is not going to give you that much benefit. So you might as well actually operate the patient.
Okay, but
And then
it is it is same for tamoxifen or letrozole, like in
no, tamoxifen,
tamoxifen.
the overall response rate is lower. It's 20% lower as compared to letrozole.
Letrozole, and in exemestane and tamoxifen, and
No,
like we,
see, there is data to say that all the three aromatase inhibitors, right? Anastrozole, letrozole, and exemestane, all the three are the same. There is data. There is comparative data, not one single trial. Like there are 3 trials that have compared 2 different drugs, and they found that all 3 have the similar response rates.
okay.
So tamoxifen is considered to be inferior to your aromatase inhibitors. So even exemestane, there is no data to say that exemestane is superior to your anastrozole or letrozole.
NCCN guidelines for sentinel lymph node biopsy.
Any clinically node negative axilla you can take up for sentinel lymph node. Basically T1, T2 or some T3 tumors with clinically node negative axilla, you take up for sentinel lymph node biopsy. The thing is, it has to be a clinically node negative axilla. Any clinically node positive axilla, there's no question of being a sentinel lymph node biopsy. They all go for axillary lymph node dissection.
Sir, in DCIS?
DCIS, that's very controversial, man, because in DCIS, I don't think there's a role of addressing the axilla itself. But sometimes what happens is there might be some invasive component in the post-op report. So overall, when you take 100 DCIS, you'll find about 3% of the patients who have an invasive component and will have disease in the axilla. So DCIS, if you are asked, a simple mastectomy is the answer. Don't talk about the axilla at all.
Okay.
Next class, we'll be talking about the chemotherapy studies in NSABP. So you have B15, B27, and some other studies, the CMF study from Bangalore. So some of those studies will be talking about. Okay.
Thank you. Thank you so much.
Thank you.